Hey, Dr. Cononello, how are you?
Hey, good to be here, Rich. Thank you.
Yes, absolutely. It's 3 o'clock, almost 3. We got about 40 people in the room right now. That's going to keep creeping up. So I figured wait a couple minutes. We'll start off by just asking everybody to key into the comment box. Welcome everybody to the event. Key in the comment box where you're from. I'd love to see that. I'd love to know, what part of the world, what part of the country you're coming from. So if you wouldn't mind and you're in the room right now, key in the comment box on where you're from. Hey, Giuseppe, good to see you, my friend. Oh, Munrith from Australia. Monique, South Africa. Janice from Cleveland, my editor. Great. Now, welcome, Jane from UK. Hey, Brandon. Jessica from New York. Awesome. New Jersey. Elizabeth, welcome. Griffin, welcome. Jade, South Africa. Oh, I love it. Love it. Ontario. Hey, Sue. Had a nice chat with Sue earlier today. Really nice. Glad you're here. Western New York. Yeah, keep letting us know. I personally love to know where you're from. One of the cool things about doing these events is that we get to, be with people all over the world. Really. One of the benefits of that. Hey, Josie. So I'm going to just wait a couple more minutes because I know we had a ton. Hey, Matt, good to see you again. We have such a nice following. We have a ton of clinicians that have just been to 10 or 12 of our events so far. So it's really nice to see everybody, keep coming back. Oh, good to see you. Okay, Jeff got on. That's good. Jeff's going to speak the next session. So he's on. So I'm going to, people will continue to come in. I'm just going to welcome everybody, to LER Expo. We're super excited to be presenting this event, Biomechanics Unlocked, next level gait analysis using artificial intelligence, sponsored by DigitSoul. I want to personally thank the team at DigitSoul, including Brandon and Josie, who helped make this event possible. During the event and after, you'll be able to check out their virtual booth. It's in the LER Marketplace. We're going to put it in the top right corner so you can see some of the products and so forth they have. We just launched this LER Marketplace where we have it's an online trade show. My name is Rich Dubin, in case you don't know that. I'm the founder and publisher of Lower Extremity Review Magazine. I'm the CEO of LER Expo and LER Marketplace, and I've been in this space for over 30 years. I just want to go over a few housekeeping items so you sort of know how to navigate the platform and, the little features that we have. So obviously you know how to comment in the comment box. If you have any questions, you can key them in there. Next to that are 3 important emojis. If Dr. Conenello says something funny, please click the laugh out loud. And if he says something enlightened, if he lightens you, which I'm quite sure he will, as will our other speakers, who knows, click that as well. If you hold it down, it blows up a little bit. It's kind of cool. And then obviously clap, the clap emoji. One of the things about these events and what makes them successful is engagement. So we could be here all day speaking to you or at you or whatever, but we need you to be involved as an attendee. So if you have questions, if you have thoughts, either type them in the comment box or, more importantly, grab the mic. And if you grab the mic, then you can come up to the stage and ask the question in person. So you're kind of with us. We don't care whether your hair's done. We don't care if your makeup's not done. We don't care if you have glasses, if you're wearing a T-shirt, whatever works for you. But we're really glad you're all here. I'm excited for this event. There's going to be some really great speakers today. Those are really the only 2 features I think you need to know. You can click the people button in the upper right. That way you see everyone that's in here. So if you see any of your colleagues or people you haven't seen in a while, you could say hello or you could chat with them directly. And then in the upper right corner, you see a little sort of message box, message icon next to your the second from the left in the upper right. Or second from the right, rather. On the left is a little comment. It'll be a number in there. So if there's 3, that means you have 3 messages and so forth. So, gives you a chance to chat with people in person. We're going to have a couple of different things we're doing this event as well, but I'll keep you posted as that goes along. So I think we should get this party started, Dr. Conenello. I'm going to introduce Robert Conenello, DPM. Dr. Conenello is a sports medicine podiatrist in private practice for over 30 years and currently owns Orangetown Podiatry. He's also on the board of editorial board of advisors for Lower Extremity Review magazine. I've worked with Dr. Conenello for quite some time, and it's an honor to be working with you today for this event.
Thank you, Rich. I really appreciate it. It's exciting to be here on this platform. I can't wait till we get together again. We can go see everyone in person, but for now, this is awesome, and it's great, and we look forward to sharing some content.
Good deal. Take it over, man.
So I'll bring over my stuff right now.
Yeah.
This is the toughest part, guys. It's just to make sure I do this part right. And we'll try our best here to do it as streamlined as possible. Okay. All right, we're getting there.
There we go. Perfect. All right, I'm off the stage. Take it away, Doc. We'll see you in a little bit.
Okay, like I said, thank you for everyone for attending, and I'm here to try to give you my take on the assessment of the runner. And I know our topic is being sponsored by Digital, and we're going to talk a little bit about AI, probably more so into question and answers. But I wanted to, give you like the basics of things that I do, and my goal is to get you thinking. We have like a very static model that we usually use nowadays, especially as podiatrists, and we want to start thinking in a little more dynamic way. I love listening to inspirational speakers, and one of the guys that everyone knows is Tony Robbins, and he always says that success leaves clues, and we need to figure out the strategies that help you get to your breakthroughs. And the way you can do that is by modeling someone else who is successful. So, that's how you can save yourself some time. So if you want to get your success, you listen to people who maybe made mistakes over time, like myself and the other speakers that could be on here today. But the same way is that, when we do a dynamic assessment of the runner, they're leaving clues. They're giving us an opportunity to say, oh, yeah, this is what's going on, and how we can get to help them and get them to reach their goals. So let's move on. This is me, nothing important. You know who I am. Okay. So we said, what are we currently doing right now? So we currently have like a very static model most of the time, but the people who I learn from the most are my mentors are people like Jay Deshari, a physical therapist from Bend, Oregon, Howard Dannenberg, really well-known biomechanist and a podiatrist from up in the Vermont area, and Simon Barthold from Australia. So if you hear some of these things, you go, wow, I've heard them say that before. Without question, I'm definitely picking and the things that I love from them. So it might be very repetitive, but that's okay. We don't, in our practices many times, we don't have a beautiful gait lab like you see in this practice right here. In the past, when I was taught, we did these static assessments. We did range of motion, manual muscle testing, deep tendon reflexes. They're still important, you're breaking out your tractograph and trying to do some measurements, but not necessary. I would much rather see people doing something more dynamically. We want to get to the root of the problem. We want to, have this dynamic model that we're actually stressing the patient a little bit. So in a static exam, like we said, we're looking at range of motion, and most of these things are done on the table, right? Manual muscle strength. We really isolate, each segment. Where dynamic exam, we want them off the table. We want to really look for that asymmetry. We want to see how mobile they are. We want to see how stable they are. We want to stress them almost to the point, we have a patient that presents with this overload injury due to biomechanics. You want to see why are they like that? What's going on that caused that? So like we said, I always say over and over again, it's the why, not the what. I'm going to play this little video while we're doing this. And you can see this is a young girl who's going through her motions. But, she came in to see me, and her main problem was that she's a runner, she's 12 years old, and she's getting shin pain. So we could focus on that. We could focus on, why does she have shin pain? Or we could focus on the fact that, there might be something more going on. And we're going to talk about her a little bit later as we go along. So just doing a static exam wouldn't be enough. So I really want to see them move. I want to reproduce their pain, see what they're doing and what makes them sore, and see where their imbalances are. And like if you're watching her right now, you can see that she kind of reminds me a little bit of Bambi on ice. She's just not very strong. And I'm going to go back to her over and over again through this whole thing. So in order to be a good runner, a runner must have mobility, enough mobility that you could transfer momentum forward. And mobility isn't the same as flexibility, because you could be super flexible like Gumby, and that's not going to help you. But you need to be able to move in such a way that you limit your out-of-plane compensations. And that's where we want to find. A lot of times, lack of mobility is what causes most of our pathology. You also need to be stable, right? So stable enough to restore the stresses. Even as a runner, you're dealing with a lot of stresses you're going to encounter, as things go along. And then you need to have power, enough power to generate lift against gravity. So those are the things that we always look for. And here you go. You have mobility, you have stability, and then you got power. That's for sure. That's very powerful right there. So when we have a runner, and the most important thing is to take a really good history. And a history for an athlete or a runner is a little bit different. So yeah, you want to do your standard medical history. And so for instance, this is a history we're taking with a pediatric patient. So this is a 12-year-old really good runner, but she's 12 years old, and she's actually running varsity in New York, which is really kind of a thing. So she's running with 18-year-olds at the same pace. And one thing we learn a lot of times is just because you're a young athlete doesn't mean you're just a small professional athlete or a small advanced athlete. You have different issues. So, your history has to start off like for a runner. It's like, hey, how much are you running? What's your pace? What shoes you're wearing? How many pairs of shoes you're wearing? What shoes you're wearing for different activities? Are you wearing a shoe that you wear for the track? Is it different than one you wear, for your long runs? How much of hill and interval training are you doing? Are you trying to really stress your body? Or are you doing the same mileage all the time? Are you just putting all these junk miles? That's not good either. What are the surfaces you're running on? Are you running on a track? Are you running on a street? If you're running on a street, do you change the area of the street? The street has a crown. Are you going towards the sides? Are you going towards the middle? Are you running on a dirt track? Or are you running on a trail? And once again, we talked about strength, flexibility, and cross training. So, are you doing any kind of muscular kind of activity that will kind of get you stronger? Because we know stronger runners are better runners. And it doesn't mean you have to be doing bench presses and power lifts, but you do have to do something, even if it's body weight exercises, to get stronger. When does the pain occur? Does it occur when you're doing certain things? Only when you're going downhill? Or is it coming, at night? Because that can, be indicative sometimes of stress-related injuries and stress fractures. To go on, we also want to know, does it improve when you're warming up? Because a lot of times our runners are not really good about taking the time they need to do a dynamic warm-up. What kind of self-treatment have they done? Have they taken oral medications? Have they tried different insoles? Have they tried different flexibility and exercises? Unfortunately, a lot of our athletes come into us now and they've done so much stuff that sometimes, they read on, Dr. MD, Dr. WebMD, and, it's maybe not all the best for them. So we want to be careful of that. What prior medical treatment have they gotten? Have they been to other professionals? Have they tried other things already? Have they had any previous diagnostic tests, CT scans, MRIs, ultrasounds? And most important to me is what the runner believes the problem to be. Because they're going to give you that clue. Like I said, success to figure out this athlete's problem is to listen. You have to be a really good listener and let them talk. When I teach my residents, I always say, listen, don't interrupt them until they're stopped talking. Then you can start talking. So that's important. You really have to be a good listener. And most importantly, I should say, is the goals. What are your goals? I'll ask every patient. I don't care if they're a high-end collegiate runner, Olympic runner that I get to see sometimes, or if they're a 70-year-old mall walker. I always say, what's your goal? And your goal might be to do more. It might be to do a race. It might be to get a PR. So you want to put that goal. I always say we're throwing that goal up there on that imaginary refrigerator. We're going to put a magnet on it. And we're going to try to help you reach that goal. So that's really important. What we're doing when we're doing a dynamic examination, we want to examine the whole body. Don't focus on just what they're coming in and talking about. Don't just look at that shin pain if that's what they're having. Look at the whole body, and that's what we try to do. And, in my practice, and I'm sure it's like this in many other you guys as well, is that I don't always have the luxury to spend an hour with an individual. I might be seeing 20, 25, sometimes 30 patients in a day. Some of them, 5 to 10 new patients a day. I have to figure out a way to be effective and efficient and have some kind of algorithm in my head to know what I'm looking at. So, the thing I do most importantly is the first thing I do is I want to see them move. I want to see, I want to review their gait. I'm going to watch them move and walk back and forth. If I'm lucky enough, I get them outside, and we do this sometimes. We have enough time with them to just run around a little bit and move and see, what they're looking at. Well, we can pick up really quick things just from doing that. So for runners, the things I know I have to have in order to be a good runner, we have to be able to have good hip extension. The thing is right now everyone's saying it's all about the hips, right? If we don't have good, strong hips and we don't have good flexibility in our hips, then there's going to be an issue. We also know we need to have good ankle dorsiflexion. And we're going to talk a considerable amount about this because if you have limited ankle range of motion, you're going to have a whole host of other issues that cause problems. And we'll see that in some videos that I'll show you today. And then first, metatarsal phalangeal joint range of motion and dorsiflexion is really important. And this is not, this is loaded, so we want to be able to load this and see what your motion is. Because in the open chain, it will look very different than it does in the closed chain. So then we also want to look at how is their not only their strength, but their endurance. So that's where things like planks, I'll ask them sometimes, show me a plank and let me see how you do a plank and show me your ability to hold that and how well you do hold it. Because muscular endurance is so important as a runner, especially if a runner wants to stay injury-free and perhaps, reach some goals that they might have. They're also going to need to have you need to have a strong booty, right? They're going to have to be able to have strength and power from the glutes to drive the body forward. It's funny, that little thing there says button stairs. That was my note to myself to put that in there, and I should have taken it out, so that's kind of funny. But it's all good. But you do need strength and power from your glutes to be able to move forward. And then, so I'll start off usually with having a patient come in, and I'll say, let's do some, just bilateral squats. So here we go back to our 12-year-old. And, we'll see her move. And she looks like she's not really having a good time doing this. She's bending over. She's very quad dominant. But then I realized, she's really tight in her calves, too. So once I put a little bit of something behind her calves and raise her up in her heel, she's able to perform this a lot better. So that's a quick, simple thing that we can all of a sudden say, wow, all right, so we know that she's got limited range of motion at her ankle joint. So, how can we, that's a strategy. How can we try to help that so we can fix the other issues that she's having? And like I said, this young lady came in with really bad shin pain. Just to give you a little background on her, like I said, she's 12 years old running varsity. And she came in to see me, and I said, do you like running? And she said, yeah, I really do like running. And she's a very, mature young 12-year-old. And I said, do you like being on the team? And she paused for a second, and her eyes welled up, and a tear rolled down her cheek. I'm like, what's the matter? And this is where you have to put on your psychologist cap, too. She goes, well, the coach said he thought I had what it took to be really good, but maybe I don't. Maybe I'm not tough enough. A tough thing to hear from your coach, maybe, maybe a little bit of a bullying situation there, too. But, we want running to be something that's positive experience for this kid. She's 8th grade. She's got a bright future. So we need to figure out what we could do. She's got enough stresses in her life. So let's try to help her get there. Then I also look at balance and single leg stance. So this guy is actually my son. He's a senior at University of Michigan right now, and was an all county wrestler. So he's a really good, strong kid, but he even has some issues, with balance, and as you can see when we kind of put him through little stresses, he has a difficult time sometimes just, with balance. We want to do this with the eyes open, eyes closed. You want to provoke a swinging raised leg because that's more dynamic. That's how we see when we do activity like running. Yeah, you can see like there's Luke. He's not having a good time just doing something as simple as reaching. So you look for foot, ankle stability or instability, the flailing of the arms, hip drop. And then over time, like this test becomes the exercise as well. And he was getting a little frustrated, that he couldn't perform this, which is kind of funny. Back to our young girl here. Here's that balanced single leg stance again. And, once again, we're going to go back to why is she getting these shin pain? Well, she's having a tough time. Look at that leg shaking, just being on one leg. And if you think about running is, a series of single leg squats. So here she is in that single leg squat. She's having a really tough time doing this. And, it's no wonder she's starting to get pathology. So yeah, and unfortunately, they're thinking that, this young girl is this superior athlete like we see, this woman over here. She's able to do this really, really well, but the 12-year-old has a tough time doing this. We don't expect them to be able to do this right off the bat. Or more advanced athletes can do things like that. Then you also want to look at the core strength with a step down. How do they do when they're really challenged and stepping down from a height? And like I'm saying, all these things I'm talking about, we can get through these really quickly in less than 5 minutes, and we can get a really good understanding of what's going on. Here's our 12-year-old when she tries to do single leg squat step downs in motion. She, even just going from a chair, we didn't even do the step downs. We just did it this way. And we so that she was really, she was good on one side, but on the other side, she wasn't so good. But she was having difficulty both times. So, this is something we need to cue and teach her how to get better. And, it's good that we had our parents with her so the parents could see it. We took video of her as well so she could see it as well and understand and have goals to try to get better. And yeah, this is an exaggerated form of step downs. You can see, like, you think it's get all kind of wonky here when they start having issues. Core strength endurance, this goes if you want to go a little bit more advanced, they have that strong endurance core, doing things that are more than just your typical planks, having side planks. If they're not able to do these things, they might not have the ability to keep themselves strong and keep a good posture when they're running. People think, well, I have a good core because I do sit-ups all the time. It has nothing to do with it. You really want to see how you do when you're really stressing the core. Head position, believe it or not, is something that's really important. We don't think about it, but when that person's walking back and forth at you, you want to see what their head's doing. You realize that, the skull is like a quarter of the body's mass is right in your skull. So if they're having like that forward tilt, and I see this a lot of time in my young 16-year-old patients because, that's the position they're in when they're texting all the time. They usually have a bit of a hip, push out too while they're doing it. So, and then especially through this whole COVID time, they've been sitting a lot, they're tighter, they're not, moving as well as they can. They can see like that, this rotation one side or the other, and even forward lean. So, something as simple as looking at that is important. Shoulders, looking for asymmetries. Are we seeing, that they're straight ahead, or is one lean to one side? Is this a functional thing, or are they born this way? Get that from the history as well. Ask the parents, ask the athlete. And then also, spinal position. Are they having did they have any kind of scoliosis issue that they didn't know of? Look for, gross or major disturbances or discrepancies. And they might even know it, but this is something, if you're not really sure, you have to refer this up to the proper doc to take a look at this as well. Hip position, okay, find your bony landmarks, and figure out, are they having, is one higher than the other? Once again, I don't like individuals to get caught up in thinking, well, this is a limb length discrepancy and we need to add something to the shoe or to the orthotic. Most of the time this is functional because of posture, because of lack of mobility, because of lack of flexibility, lack of strength. I just had a woman that came in here yesterday. She happened to be a 70-year-old nun. and she loves walking every day. She goes out and she does her 2 miles every day at her decent pace. And the nurse in her facility said, "Oh yeah, I was sent here to get a lift in my shoe." And I'm like, "Why?" And she said, "Well, watch me walk. I look a little off." And sure enough, she kind of looked like the young lady here on the left-hand side. When she was walking, her shoulders were a little off too. And I put her through some of the simple tests, and she was really weak on one side compared to the other in her hips. So rather than just stick something in her shoe, I want her to get stronger. So we're gonna work with the therapist to get her stronger and see where we can get her to. Knee position obviously is important as well. We need to see where the patella is, where it's functioning, where it is. We want to see that they have any knee valgus, if they're having too much internal or external rotation. And you can see this obviously when the patient is walking towards you, walking back. That's important to see that. Have them when they're doing their squats, look at these things as well. Ankle range of motion. This is probably this and first MPJ range of motion, I think, are the things that I find the most amount of issues that I find in my athletes, as well as hip issues as well. But limited ankle range of motion is a risk factor in both acute and overuse sports injuries, because if you don't have enough range of motion in your ankle, I'm not sure if this is the proper video we're going to see. Yeah, we're just trying to assess her range of motion. But it can lead to things like increased knee valgus, increased pronation, increased trunk lean, greater landing impact. All right, if you have a greater landing impact because of all this, guess what's going to happen? You're going to have an increased risk of stress injuries, right? So we want to decrease that as much as possible. And we want to just decrease, the amount of ground reaction force, because we know that can happen as well. So the ways you can really test this is just doing a simple lunge. And what I like to do is see if they can get their knee to the wall, and they should be within 10 centimeters of the wall, getting that knee without raising the heel on the other side. And you'd be surprised, some of your best athletes do not have the ability to do this. Some of your best athletes also don't have the ability to just stand on one leg, like you saw with the balance with my son. But you want to do that and see, are they able to do that? Are they lifting up? And you want to also do that deep squat. We want to see, we assess bilaterally. And I think we have another video of that. Yeah, here's Luke doing his. And we saw, what we did is we were having him do squats, and he's leaning forward. He has this quad dominant appearance. And then we just put a little bit of foam behind his heels, and he was able to do this so much better. So yeah, that's where we're like, Luke, you feel it, you see it. This is what we have to work on. We have to get you more flexibility, or else you're going to lead to other issues down the line. Posterior tibial insufficiency, this is a big one, right? So, and this unfortunately is what most shoe stores, unfortunately a lot of doctors, including podiatrists, are looking at. They're looking at just this static movement, not even just static. Is their foot rolling in so much? So you can't tell if this person has any pathology from looking at this. You say, yeah, I have a low arch, I have a foot that's rolling in. It doesn't mean necessarily they're going to have pathology either. I have patients that come in like this, and sometimes they're just as efficient, and they've learned strategies to get themselves better. You can also teach them how to make this stronger by doing certain exercises as well. But it can, if you have a lot of this issue, it can lead obviously not only to posterior tibial issues, but the soleus and gastroc strains and issues like that. Sorry for the typo there with gastroc. So it definitely depends on stability. Sometimes the stability of this is if you don't have good intrinsics of your foot. We're going to talk about that in a second as well. So also just looking at grossly, you want to see, the out-toed or the in-toed, what does it look like? The rear foot analysis, when the stores are looking at that and they're making recommendations of shoes, that is not a good thing to do anymore, because you need to, you're only getting about 20% of the information when you're looking at them from the rear. You got to see things from all different angles. Okay. Yeah, you can have some pronation, but pronation doesn't have to be a bad word. Pronation is a movement, as we know. It's not a pathology. It's just a movement. Are they having pronation that's causing them to have, pathological movements during a certain phase of the gait? That's a whole nother story. Intrinsic foot strength, I love Irene Davis, PT from the Spalding Clinic in Boston. She calls it the foot core. I love that word. I think it's really what it is. We think about our lumbosacral core. We're dealing with small muscles that help drive the body. The foot core is the same kind of thing. We're using the small intrinsic muscles, those 4 layers of muscles that kind of stabilize the foot. In particular, I find that like the pronated foot requires the intrinsic muscles to work harder. And sometimes my patients just don't have the ability to use those muscles all that well, including, the flexor hallucis brevis and the abductor hallucis to hold their foot in the right position. So there's, I ask them really quickly, can you do, toe yoga? Just seeing if you can raise your hallux up and down and put it down back and forth. I would have to tell you that 90% of my athletes that come in with pathology cannot do this. Their neuromuscular connection has been shut off. They don't have the ability to move in this pattern, and you have to relearn them. I had a woman that came in today. She's like, and I take off my shoes and socks sometimes and show them how to do it. Like, how can you do it? She's like, I can never do that. I can never do it. So I gave her some clues and cues and how to do it, and we worked on it for literally about a minute. And then all of a sudden she goes, oh, I'm doing it. And yeah, because you got to learn how to do it. You have to learn how to get stronger. It's so important when we move and we run, we have to pivot over that first metatarsal phalangeal joint. And if you're not able to really push that toe down into the ground, you're going to have an issue. So in the flexor elusive brevis test, is like we just said, it's that toe yoga test, absolutely. You also want to check for first-rate dorsiflexion. Like I said at the very beginning, we don't want to do this in the open chain. We want to do this in a closed chain. So we want the ankle at, maximally dorsiflex as much as we can. And we want to load the foot and then see how much motion we have there. Is it being caused because they have lack of mobility? Do they have a bony block? Obviously, as docs, we're going to be taking some x-rays perhaps if we're thinking it might be that, to understand if there's more to it than just lack of mobility and lack of flexibility. Yeah, and there you go. So the gait exam, I don't usually put my individuals on treadmills, but if you are going to go on a treadmill, the individuals have to adjust to that treadmill. You want to be able to observe them, like I said, from all planes, and that means front, back, side to side, and if you even can get to see them from top down, because there's a lot of rotation, obviously, in gait, and we want to see, do they have a lack of mobility and rotation. One of the things, the tools that I like to use in my practice, goes with that lack of ankle motion, lack of first MPJ motion, is to use something that Jay Deshari has called a Mobo board. If you don't know about it, go check it out on moboboard.com, because he always says, like, our foot isn't a brick. We're not just like moving up and down on the gas pedal. When we run, we're twisting and having some torsion that goes through that first metatarsal phalangeal joint. And he's developed his board to help cue people to do that and train people to do that. So that's really important. So once you get them on the gait and watch them move, if it's on a treadmill or if it's perhaps outside, use all those clues and cues that we got from before, and then kind of see what's going on. The thing that my biggest pet peeve is when these people go to these running retail places where they're put on a treadmill right away, and they may never have even ran on a treadmill before, and they're not adapted to a treadmill, and they're going to walk and move and run differently. So how could they even make a diagnosis from that? And who are they for making diagnoses? We're talking about people who work in running retail. Maybe their claim to fame is that they were a good runner in high school, but they're not a biomechanist. They're not an athletic trainer. They're not a physical therapist. They're not a podiatrist or an orthopedic surgeon who's been trained to understand foot motions. Just because they have an algorithm in front of them and they want to sell a pair of motion control shoes because they say your rear foot is pronated, that's not the answer. So I think that is something we need to fight up against, and the only way we're going to be able to do that is if we get good at doing these things ourselves, or else then it's our own fault. We have to get really good at understanding pathological movement patterns. Some of the recommended readings I would definitely suggest are things like from Jay Deshary. And I'm a big Jay fan, as you can see. But Athlete Anatomy for Runners and Running Rewired, take the time to read these. These are Bibles if you're going to be a biomechanist. And I'm sure many of you have these on your shelves right now, but I think it's really, really important. Great time to learn. So in summary, whatever you're doing, you want this to be a quick and easy dynamic test, minimal time added when you're doing this, uncover the deficiencies. And then once you see the deficiencies, do what you can do to help, cue the patient to make them better. Like I said, many of the tests become the exercises themselves, like the single leg squats, and just it's very subjective. So, you're the one who's looking at it, and you want the patient to feel it. You want them to buy into it. I know this talk is being sponsored by Digisol, and I think what they're going to offer is the ability to utilize some AI in the near future, where we can actually, get some data and use that data to augment our dynamic assessment. And boy, then we're really sitting in the driver's seat where we could really offer them, real-time data as well as the art of what we do as clinicians. I think that's really going to be the holy grail. So I thank you. This is me right now. I'm sitting in this position right now. I do a podcast. If you guys ever want to listen to my podcast, it's called RPM, the number 2. RPM 2. We have lots of different people on there. We talk. So I thank you for your time. I hope that we were able to gain some things out of this. I hope I didn't take up too much of your time, and I'm looking forward to your questions at the end. Don't forget Digisol Pro. This is their well, they don't have their website on here, but digisol.com. I'm sure digisolpro.com is where you can find them. And I thank you so much, Digisol and Lower Extremity Review, for your opportunity to do this.
Awesome. Thanks, Rob. Really great, really informative, really great, really practical. I think that's the part that I love about, what you share is it's just very practical. So we have actually a couple of minutes. We're going to take most of the questions in the roundtable, but Jeff Lambert, Shimo's presentation is next at 3:40. So we literally have about 3 minutes. And so Munrith asked, how long would you spend for initial assessments?
Yeah, I guess it all depends upon how your practice works, right? So I think you need to give an initial assessment anywhere up to a half an hour. If you could do it in less time, kudos to you. I personally am trying to do these. It's almost like a screening that we do in the first visit and to try to figure out things. So, we could try to do them, in 20 minutes. But I think that's what you need to do. As long as you feel good at doing this, it's, it shouldn't take all that long.
Yeah. And then we got another question from my friend Bob Schwartz. It's actually 2-part. What is the role of footwear in assessment and solutions? And what about shoe wear patterns to assess?
Yeah, footwear plays a huge role. Like we said at the beginning, I think it's really important to go to a retailer that has a wide variety of shoes. For me, I think the most important thing about shoes is does the patient find it comfortable? I don't think we should be caught up into the whole fitting a shoe for a person's foot type. Wear patterns are, I think if they're really asymmetric from one side or the other, they play a role. But for the most part, patients come in to me and go, look, the side of my shoe is really wearing off a lot. I'm like, that's usually what happens. We land on the lateral side of our foot and go forward. But they can give you clues and cues. I think more importantly is the wear pattern on their feet. We might see a lot of like callus and change in hypertrophy of the muscles and the skin of the foot.
Yeah. All right, so we do have another question, but we're going to move on to the next session. So, Rianne, I'm going to keep that out, distal tibia bow, into consideration. So we'll look at that, pop that question in at the round table. Rob, I'll see you in the next session.
Okay, thank you.
Okay, bud. Thank you.